got it.
There we go. Very good.
Okay, I'm going to talk about the different models that we're seeing for physician organization in the market now. A lot of it has come about from the passage of the Accountable Care Act, but also a lot of it has come about because of pressures from the employers to reduce costs. And I've been around for a long time, and to me, this is a bigger sea change than the prospective payment system for hospitals. It's going to be more like when they actually did pass Medicare and Medicaid legislation. And in the first few slides that we have, what I'm going to be showing you is how we're transitioning from fee-for-service to value-based purchasing, and some statistics from a survey that was done this summer asking the chief executive officers of hospitals and hospital systems what they're currently doing and what they expect to be doing moving forward. And I had originally anticipated that what we were looking at is we were looking at 5 to 7, maybe 10 years. We're looking at 3 years from now, and it's going to greatly impact the individual providers. If you look at the actual statistics on which models are moving forward, the first one where it talks about what are you doing now, and you can see that the hospitals are, the majority of them are doing employment. We knew that. Clinical integration, and we're going to talk later about clinical integration, patient-centered medical homes, and the shared savings contracts. We've seen that with the Medicare Advantage. We're now seeing it in Houston with the commercial, bundle payments, and co-management agreements. And then the next question they ask them, what do they expect to begin in the next 3 years? Well, 33% are going to enter into risk-sharing arrangements. And these risk-sharing arrangements are no longer limited to Medicare Advantage. These risk-sharing arrangements are with commercial payers. It's a shared risk between the employer, the insurance company, and the providers. And we know that Memorial Hermann this past year has $56 million to share with their providers in the savings from their Medicare, 25,000 lives in their Medicare product. Bundle payments also is big. The Centers for Medicare and Medicaid Services just issued over 4,100 grants in August to different organizations to test the bundle pricing methodology for outpatients. And we've seen it for inpatients for a long time. John Adams is going to talk about it later, but now we're seeing a huge move on the outpatient level. Then they ask the same group of executives what they're planning on doing with their primary care physicians. And they're looking at clinical integrations with their number one, patient-centered medical homes, ACOs, employment, and then shared savings. Bundle pricing and co-management, those aren't as relevant as they are to the specialists. Then when you look at the models that they're looking at for their specialists, clinical integration, bundle payments, ACOs, employment, shared savings, and co-management. So this is what is actually happening. This is 311 CEOs from around the country on what they're looking at doing. And as I mentioned earlier, cardiovascular providers, they started in 1984 with Denton Cooley's group and did bundle pricing, although they called it package pricing back then, with Cigna for cardiovascular. Then the next year we saw it done for orthopedics with an orthopedic group in Michigan. The shared risk, what's happening there is that the ones that learned from the Medicare Advantage product, the Cigna They're doing it with Kelsey Sebo on the City of Houston. Memorial Hermann is doing it with Aetna on the shared risk, shared savings agreements. We're seeing a move toward risk sharing in Houston. This is just the beginning of it. Aetna and Cigna are on the leading edge. Both of those have Medicare Advantage products. They're taking the lessons they learned with the Medicare patients, with the chronically ill patients, and they're implementing it with their commercial patients. We're also seeing what they call medical tourism, and to most of us, medical tourism is people coming here from other countries. Well, medical tourism in this market, in this model, is that Walmart has contracted with Scott & White and 2 other organizations to do bundle pricing for their hearts. You've got PepsiCo working on they're doing that. You've got payers doing it with Johns Hopkins. We're seeing where they're taking their high risk, high volume, high cost, and they are sending it, all of their patients, in some counts worldwide, to a single provider to bundle price it and give you a better rate and higher quality. Clinical integration, that is the big thing that is going on right now. By clinically integrating your primary care with your specialists, coordinating the care, what you're going to be able to do is reduce the cost because you're going to be more efficient and you're going to coordinate the care. And we're seeing a collaboration. It's a collaboration between physicians and hospitals to manage the patient, to identify and manage the care. One of the hot topics, buzzwords right now is called predictive analytics. And all that is correlation analysis and regression analysis to identify the train wreck and to see which patients are going to be that train wreck so you can put the necessary resources there on that. Now, clinical integration is not employed physicians. It's not physicians and hospitals getting together to beat the antitrust laws. It's not a way to circumvent antitrust. And it's not run by the hospital. Stuart's going to talk in a few minutes about a landmark decision of February of 2013 where the FTC granted a waiver from antitrust because the group was clinically integrated. And you'll see, he'll tell you what it's legally to the FTC, what it is and what it isn't. Accountable care organizations. Accountable care organizations came about, well, we had them before, but we've seen an emphasis in them, the Accountable Care Act, and they focused on the Medicare population. You were assigned Medicare patients based upon the primary cares in your group. And unfortunately, this is unlike the Medicare Advantage. You cannot keep those patients in network in an ACO like you can in a Medicare Advantage, which is an HMO product. However, many people went into this, like Memorial Hermann, because at that point, the only way you could get the waiver for antitrust from the FTC was if you were an approved Medicare ACO. And the plan always was to move it to the commercial population because that's where you get your biggest bang for your bucks. And so what we're seeing now that we have a different model, the PHO, the Norman, Oklahoma Physician Hospital Organization, where as long as you're clinically integrated, you can negotiate rates and you have all the advantages, waiver from antitrust, that the Medicare ACO allows you to without all the risk of the Medicare ACO. And it's very high risk when you're dealing with those clinically ill patients. So we're looking at a whole new change. Other models that we're seeing are group practices without walls, and Dorma's going to talk about that later and about the specifics on that, but that's a model that's a true group practice. So again, you can negotiate rates and not be in violation of your antitrust legislation. You can be a clinically integrated organization without being an IPA, Independent Practice Association like Renaissance, or without being a PHO. Baptist System in Birmingham, Alabama, they have 6 hospitals. They have a clinically integrated organization that covers the medical staff at those hospitals and the hospitals, and they're not a PHO, they're not an IPA, they're not an ACO, they're just a clinically integrated organization where the physicians and the hospitals have come together. But what you're going to have in a clinically integrated organization is physician leaders and physician leadership. And you're going to have the technology, a very robust IT system to be able to collect the information. Wes is going to talk about those issues in a few minutes. And there are certain things that you're going to have. It's not something the hospital just comes up with and tells you what to do. And you're going to develop the clinical protocols, evidence-based medicine, to treat the patient. So Stuart is going to talk to you now about the legalities of a clinically integrated organization.